Hi, my name's Darren Chandler, and I'm going to give you a quick overview as to what go-to imaging is all about. About 14 years ago, my colleague and I, Robert Shanks, we trained as osteopaths and saw many people with lower back pain, like most therapists do. And I just felt a little bit limited in terms of, patients were coming in with their scans and asking me to read them. It wasn't the scan, it was the report. Quite chronic lower back pains, had for a number of months, seen various therapists, weren't getting better. And I don't know, I just always felt like I kind of could have given more if I could have understood a little bit more about the imaging side and sort of what the sort of pain consultant was going to do, the surgeon was going to do. So we was very fortunate. Robert and I one night went to a local hospital in the area, and there happened to be a consultant radiologist whose name was Dr. Sajid Butt at the Royal National Orthopaedic Hospital. And he did a talk on, say, the causes of lower back pain and the sort of management and treatments via what's been seen on their MRI scan. And I have to say, it was completely, massively inspiring for me. I was in awe of the chap because he seemed to be able to identify via kind of clinical picture history, examination, and then sort of combine it with the scan. It was almost like the scan was a kind of add-on part of the sort of diagnostic puzzle, if you like. And I just liked his approach. So Robert and I approached him at the end and asked if we could sort of watch and shadow and pop along to the hospital. And thankfully, he said yes. So it kind of led us doing, being really in his company for about 14 years. And even to this day, we're best friends. We sort of speak on a daily basis. We share scans, share patient sort of case histories. And obviously through him, it kind of opened up a new world of sort of meeting consultant surgeons, consultant pain specialists. And obviously we were starting to shadow them, going to their clinics, go to MDT meetings. And again, a lot of it was all based on scan and what was the clinical picture. So the kind of two were very much, overlapping. And although it didn't start sort of, if you like, out as this, but as we started to become sort of competent in reading scans, we started to realize that there was a big discrepancy in actually what was being reported by some radiologists and really what was actually on the scan itself. And that then started getting us thinking that, wow, if this was taught at, degree level or postgraduate, and we could sort of, if you like, impart some of our knowledge that we'd gained through our journey into sort of the physio, the osteo, the chiro, GP, Dr. Weld, if you like. So hence, that's where we are today. We'll be running various webinars and tutorials and even going to sort of tutorials around the country, hopefully imparting some of our knowledge. But just to give you a little overview, I'm just going to share my screen just here. And let's see if we can have a little quick look at this. So this will give you a little idea of what's sort of coming up really in future lectures. But you'll clearly see on the left-hand side, there's a sagittal lumbar spine. And you can see here that the intervertebral disc just here is missing. Spinal canal looks capacious. The disc looks generally unremarkable. It's quite a question mark what's going on here. Spinous processes here, but they're missing at this level. Again, what's gone on, and is this potentially something that's relating to the patient's pain? On the right side, you've got the axial scan here. And I just want you to have a little focus on the little grey dots. Now, that's the spinal canal, and they're the descending nerve roots. You can also see the facets bilaterally, but the spinous process is missing here. This patient had considerable pain when I sort of particularly done this MRI scan, but that was sorted. And then sort of 2 years later, she returned to the clinic in quite considerable pain again, slightly different this time in nature in terms of the way it presented. And we did a second scan. And when you look at this scan, you can clearly see something's not right now with the spinal canal and the descending nerve roots that are coming down. And you can see there's almost like a bubbling of the fecal sac. Dura looks slightly not as it should. And if you look on the right side, you can clearly see that the descending nerve roots have now disappeared. So, how does this sort of combined with the patient's clinical exam and history taking. So again, it gives you a big part of the puzzle. Why has it changed, and how potentially is this causing the person's pain? You'll see lots of these, and this is sort of something we would like to teach more, is that the MR arthrogram that I sent for a right hip, this was a lady that had a trauma and she had pain in her groin, medial sort of thigh, etc. And I just want you to look at the conclusion. The conclusion at the bottom reads that the MR arthrogram of the right hip does not demonstrate any obvious labral tear, and there certainly is no femoral acetabular. Well, I wasn't convinced by that, so we had another little look and we did a second report, and you can clearly see another consultant radiologist now writes that the right acetabular has a labral tear. If you have a little look, the tissue here is the labrum of the right hip. It's a little bit faded, but you can clearly see there's a gap just here. So here's one part of the labrum, here's another, and there's a gap in the middle, and this is where the tear has occurred. But more so, if you look onto the right screen here, you'll see here is the femoral neck. Now there is a little bump, a little sort of raised area, and that is a cam deformity. So this patient has a femoral acetabular impingement. So, you know, if you go back to the original MRI report, it says there's no femoral acetabular impingement and there's no labral tear, when actually there is both. So it's quite worrying when you see this, because I'm literally seeing it sort of day to day and every week. And, you know, unless you're sort of proficient in looking at the scans, it's very difficult to pick up. Now, here's another picture. Again, you know, on the left, it's a sagittal, and this is a supine scan. So the patient was laying down. But if you look at the right, this was a standing scan. Now, when this patient stood, that's when they had their pain. And you can clearly see there's some sort of microdynamic shift, and you'll see that the L4 vertebra is actually going posterior in nature compared to the L5 by about 4.2 millimeters. Now, does that have effect on his pain? It may do. It might not, but again, it's something that's been spotted, and with good sort of core strengthening and just sort of, you know, making the patient understand that this is potentially, you know, the cause of the pain, then it's brilliant, because it just furthers your, you know, treatment approach. And then you get scans like this, you know, people coming in with mid-thoracic pain, and it's, you know, it's very stiff, and you wonder what these conditions are. You know, it's got lots of calcification down the right side of the vertebral bodies. And again, this is stuff that we'll teach and show in sort of further webs, seminars, etc. And lastly, again, you know, just another typical conclusion, but pins and needles in this patient in their left leg, standing, pain in the left side. And the conclusion was that they had some wear and tear in their disc and facet joints at L3, 4, and 4, 5, but there's no evidence of neural compromise. So there's no nerve root compression, but it clearly states the patient has numbness in the left leg. We look at the MRI scan. Here's the L5 disc, and you can clearly see there is a disc herniation here, which is paracentral. And here you can see that the exiting L5 nerve root is swollen, and that disc fragment is affecting the exiting root. And if you look at the axial view here, you can clearly see there is a disc protrusion here, which is a far lateral. And again, that's affecting the exiting L5 root. So once again, we go back to the scan, and it completely, you know, says the complete opposite. So it doesn't even mention this pathology at L5. So again, I can't sort of stress enough, this is why you should, you know, get on board and start at least getting the basics and the understanding as to how to view your patient's images, because we've just found it phenomenal in terms of management and sort of even just contacting other pain consultants and surgeons. It's just great to have the same rapport, and you're all sort of speaking from the same hymn sheet, really. So hopefully in the future you'll watch out for various webinars on GoToImaging, and look forward to seeing you all.